Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
In today's episode of the podcast, we will discuss point of care ultrasonography, POCUS, in critical care. The application of ultrasound at the bedside continues to evolve and grow within critical care. However, there is still significant variability in its adoption among ICU practices. In today's episode of the podcast, we will discuss key trends in technology, the relationship of POCUS to consultative ultrasonography, growing clinical applications, and challenges that we might face with POCUS. We are honored to have Dr. Jose Luis Diaz-Gomez as our expert guest today. Dr. Diaz-Gomez is the Chief of Transplant, Cardiovascular, and Mechanical Support Critical Care and Director of Critical Care Echocardiography at Baylor St. Luke's Medical Center in Houston, Texas. He is also a senior faculty in Cardiovascular Anesthesia and Critical Care at Baylor College of Medicine in Houston. Dr. Diaz-Gomez is a recognized expert in critical care echocardiography and the lead author of a recent review article on this topic in the New England Journal of Medicine. A consummate clinician, a master educator, and a wonderful person. Jose, welcome to Critical Matters.
Dr. Zanotti, thank you so much. It is my privilege to be in your now very famous podcast. I have no words to express my appreciation, and I would say most of my friends are always very, very committed to your podcast. So once again, I'm looking forward to have one of my best discussions in my life with you.
Excellent. And as I said before we started recording, this is a conversation among friends. So it's Sergio and Jose. That's how we roll here.
Okay.
Jose, let's start with terminology. Just define POCUS for us and what it is and what it's not.
Sergio, this is probably one of those moments that I feel absolutely humble in my life. And when we submitted a previous work to the New England Journal of Medicine several years back, was actually it was a video in clinical medicine regarding the left ventricular systolic function. And at the time, we actually have, of course, a very, very rigorous review. And as far as the terminology is concerned, we needed to actually come to an agreement that we'll not be using ultrasound. We're going to be using the term ultrasonography. So in our review article, we define point of care ultrasonography, defined as the acquisition, interpretation, and immediate clinical integration of ultrasonographic imaging performed by a treating clinician at the patient's bedside rather than a radiologist or cardiologist. That definition has created so much controversy. I already have been invited to meetings with many parties, and on behalf of the authors of the article, Dr. Paul Mayo, Dr. Seth Coney, and myself, we do believe point of care ultrasonography is well defined in the article. So somebody will tell you, well, Sergio, what's the deal between saying ultrasound and ultrasonography? Well, the fact of the matter is that when you are just describing the tool is ultrasound, but how to apply the tool is ultrasonography. And I'm telling you, in that previous process with the New England Journal of Medicine, we needed to accept that moving forward, we're going to be using ultrasonography. So we are all focused on knowing how we're going to make the best application of a tool. And that we will go more in detail about it. But it's not about the gadget. It's about how we will incorporate in our practice. So I just wanted to clarify that a specific term of ultrasonography rather than the ultrasound. Thank you.
And that's a great point. And it just it's impossible for me to not think about the stethoscope. And when I was preparing for our conversation, I came up about a quote from over 100 years ago, Jose. And I'll read it to you and I'll let you react.
Sure.
That it will ever come into general use, notwithstanding its value, I'm extremely doubtful, because its beneficial application requires much time and gives a good deal of trouble both to the patient and the practitioner. That was a comment on the stethoscope when it first was presented as a tool. What do you think of that and how it can be made into an analogy into your journey with ultrasound as an anesthesia critical care clinician?
I think this is demonstrating once again why you are one of the most educated, eloquent, and articulate friends that I have. And I have to say that if we apply the same to ultrasound and ultrasonography in that specific, sequence, meaning incorporating this in our practice, that's what's going to happen. It's a matter of time. The widespread availability of the tool is there, but think about how people are using the tool. They are adapting that tool utilization to the scope of practice, to political issues they might have in their institutions, to lack of resources in some parts of the planet. So because of that, you just inspire me. I think what you just described is what actually will describe the utilization of point of care ultrasonography moving forward.
And I think it just speaks to how it takes time in medicine, even though we've been talking about point of care ultrasonography for some years now, as we mentioned earlier. As of now, in Houston, where we both are, there's probably plenty of critically ill patients who are having problems or questions that could be answered with the point of care ultrasound that are not having that as part of their care. And yet there might be some that do have it as part of their care. Yet we don't see anybody walk around the hospital without a stethoscope today. So I think that over time, we definitely need to move in that direction. It's just a technology that is 150 years newer and right and better. But let's dive into this then, and why not talk about technology a little bit, Jose? So obviously there's been an evolution in technology that always is required for adoption, right? One of the big limiting factors many years ago was just the acquisition of technology that allow you to obtain ultrasonographic images at the bedside. That was prohibitive for most clinicians. But there's been some key trends in the evolution of ultrasound machines, but also in other technology that might really have an impact on the adoption of ultrasonography throughout the critical care arena. Could you talk about those?
Absolutely. Sergio, without having any bias, some of the largest and more prolific and successful companies in the planet have been able to evolve in that direction because only one single word: simplicity. They made things simple. So if you think about it, over the last decade, what has happened with point of care ultrasonography is that the technology has made it much more simpler, that application to the clinical practice. Why? Number one, the handheld ultrasound systems became more affordable. I'm not going to mention any specific names here for obvious reasons, but when you have a device that probably is in the range of the $2,000, then it became more accessible to others that need it. The probably much higher presence of internet in every single country in the planet and having sophisticated wireless technology, then everything comes together. So now from there, now we have a tool that I will tell you, and let's do a contrast what you just said about the stethoscope. Would you imagine that the stethoscope will bring pulmonologists anesthesiologists, and paramedics together, that's unreal. Ultrasound does. Ultrasonography does it. Why? Now you have these wireless technology, more affordable handheld systems, and people want to collaborate. They want to take better care of their patients. So I have engaged since probably in the last 7 years in telementoring. I go to some countries, some places. Hey, would you mind? You can guide me. Sure, absolutely. If I can, then now in real time, I can guide somebody how to improve the skill and actually even make better diagnosis. The companies have been actually able to produce some specific advancements. For instance, now you have silicon chip arrays microsensors instead of piezoelectric crystals elements to make one probe that actually can have a wider range of frequencies. So instead of having two probes, one for linear and one for phase array to take a look at the heart versus blood vessels, now you can have that capability in only one probe. In moving forward, we're actually now empowering the tool with different modalities of ultrasonography, such as Doppler and mode. And even you're going to incorporate now analytics and quantitation features if you are now even involving the concepts of artificial intelligence. Are you seeing that repertoire? It's not that amazing that in the coming decade, you can have something connected to your iPhone or other, Galaxy phone, whatever phone is, whatever smartphone is, and then all of a sudden you are connected with an expert, and all of a sudden you have tools to have a more objective evaluation of your patients. That's tremendously helpful from the technological standpoint. That's not an issue, and it just will be promising and promising year after year.
Yeah, certainly the evolution is a rapid pace. I mean, and we think about our lifetimes, just what has happened with computers, right? I mean, very similar or analogous evolution we're seeing with ultrasound. I remember that obviously when we were all training, there was echocardiography that usually would be ordered, and somebody would do it. Either a technician would do a transthoracic, or a cardiologist would do a transesophageal, or anesthesiologist would do it in the OR. And that's the way you would get these images. And now, like you said, I mean, there's people walking around the hospital with their own ultrasounds. There's portable ultrasounds in a lot of ICUs, and it's being utilized a lot more. But I want to probe a little bit more into that last portion that goes beyond the evolution of the hardware, which is the software, right? Which is the AI. And that seems to be rapidly approaching us, right? And my vision of AI in medicine is not that AI replaces our thinking, but that it supplements our thinking, and that a clinician plus AI is the way to go, probably. And that seems to be happening already in ultrasound. Can you talk a little bit about that, Jose?
Well, I'm really impressed with this interchange as colleagues and friends, and now I understand we get along so well. There is a book by author. His name is Eric Larson. The book is The Myth of Artificial Intelligence: Why Computers Cannot Think the Way We Do. And although I have participated even in one study, having artificial intelligence to have automated, calculation of ejection fraction, I can tell you that we need to put things into consideration. In that book, you have the three different reasonings that any POCUS user should keep in mind. We have deductive reasoning, we have inductive reasoning, and we have abductive reasoning. So I don't want to confuse the podcast membership. As you know, I love Latin, in that deduction, induction, and abduction, actually, all those three words are based on the Latin ducere, meaning to lead. So when you have deduction, derives from generally accepted statements or facts. When you have induction, leads you to a generalization. Those two, we got it. And that's the reason artificial intelligence is powerful. However, the prefix ab for abduction reasoning means away. And this is the component. That away means that sometimes we will have the application of POCUS in a clinical context, and the common sense that we might apply sometimes in some of our clinical decision making it cannot be incorporated at this time in artificial intelligence. Artificial intelligence is not up there. And for that reason, I can go on a specific clinical situations later on with you. So the way I look at it is I'm open to the concept, but it will take many years to really have that equalization on performance to say that artificial intelligence will solve all the issues of POCUS. Perhaps the application that is coming really, really fast, and I really applaud all the success that the software company have done on this, is the prescriptive imaging, meaning that when you are procuring the echocardiography view, you will have guidance to get it right. But one thing is to have an image. Another thing is to put that image into the context and take decisions for your patient. So I'm open to it, but I will remain critical moving forward, and I will make sure that the application of point of care ultrasonography is on the highest benefit for patient safety moving forward.
Excellent. And I think that this is a good place to start moving towards the clinical application of a point of care ultrasonography. And perhaps we can start with its use as a guidance in performing procedures. I don't have data on this, Jose, but I would imagine that is probably a more common use. I think that it's probably more likely that even people who were trained before the era of point of care ultrasonography are utilizing it for central line insertions and for A lines. But why don't you tell us a little bit about, in the critical care context, how do you see this use of guidance in performing procedures? Maybe some common procedures first, and then some more novel or less common procedures that you've seen it being utilized for.
Thank you. That's a very important question. And I would think as the procedural application of point of care ultrasonography is a valid one, separate one. It's separate from the diagnostic one. So when we're doing procedures, if you are able to have real-time imaging, and that's the reason I was inspired to do one of my previous studies, performing thoracentesis or big catheter placement, and the real-time ultrasonography is different than marking, And I'm biased about it, but when you're talking about the applicability itself, I will always say, why cannot be done under real-time ultrasonography? That's the first principle. Number two, I think for all your POCUS membership, is very valid that probably the most mature application, nobody can question, is the vascular access of the internal jugular vein. When you think about it, the insertion depth to get that vessel is probably close to 1 inch the majority of the time. And you even don't remember how much that inch is. It's just fold your thumb. That's the reason in Spanish, that's a pulgada, 1 inch. You basically bend your thumb, that distance from the tip of the thumb to what is bending, to the joint, interphalange joint. That is the distance that I believe 99% of the intensivists, the critical care providers, should feel comfortable, and they should feel they are doing something safely. You are in that range. And that's actually one of the principles I apply on a daily basis. So you master that, and from that one, you actually start migrating to any other body fluid you need to drain if you need to drain for therapeutic reasons or for diagnostic reasons. Let's say you have somebody with pneumonia. You want to see whether or not it's an exudate. There might be some findings with ultrasonography that's more for exudate, but you still want to do the likes criteria and all that. You go with that principle. So that's the way a novice should start. And then I can show you cases where more challenging procedures, such as a pericardiocentesis, my approach, and I have showed this in meetings, that approach of having even 1 inch depth. I have a case where I did an apical approach in the apical view, 2 centimeters. I was in the pericardial space. I inserted the pigtail and I drained half a liter, and the patient had a good outcome. So the bottom line is you need to know how to start with the safest, principle, and you go from there. And you always need to understand that the real-time visualization of the tip of the needle is an absolutely non-negotiable aspect. You need to see where that needle is going. You might become more sophisticated. Oh, Jose, I want a microconvex probe, or I want the in-plane approach, or out-of-plane approach. These are, variants to the performance of the procedure. But the fact of the matter is that you should try to see the tip of the needle as you're advancing in the body, and you can do that. And right now we have many millennials. There are folks that actually are really good on video games. There is research in that regard. They compare video games performance between female and male provider. By the way, there is no difference. There was no difference. This is all this kind of knowledge that is out there in terms of how you improve your visual spatial orientation with ultrasonography. Because in the end, it's how you're moving your hands and how you're visualizing the tissues. So I hope with this general principle, you imagine how really can enhance the safety on the procedural aspect of our practice, but you need to make sure you have control over the visualization of the needle. It's just not exploring blindly. No way. You need to see the tip of the needle.
Excellent, and I think that's a very valid point and something that all of us, should keep in mind. In terms of other procedures, Jose, could you expand maybe on some procedures that maybe 10 years ago or 5 years ago you were not doing with ultrasound that now you are?
Absolutely. So, 10 years ago, paracentesis. Yeah, we were all afraid of hitting the epigastric artery. Nowadays, you can do Doppler, you do it big time. 10 years ago, when I have issues finding the good spot to have actually having an LP, having attempts, multiple attempts, and being afraid of causing a hematoma, now you can do a lumbar puncture with ultrasonography. 10 years ago, you probably were not that, you didn't have alternatives to have a pericardiocentesis. Most of the techniques were actually only subcostal approach. Now you can do apical and even a parasternal approach. So these are just examples of how we have been able to really, really advance our practice. So, lastly, I would say this. I'm envisioning how the ICU will have even a separate suite that we are able to actually embrace the next level of performance with procedures. And by the way, in one of the first institution after I was out of training, we actually had it, and probably they still have it there. But 10 years later, I can tell you, I will advocate even in the designing of the ICU, having a room to have procedures, having, even in the future, fluoroscopy in addition to ultrasonography, that will avoid patients even traveling in an elevator and having safety issues. So I'm a very, very strong advocate about empowering intensivists for proceeding with ultrasonography.
Excellent. And we'll talk more about the training towards the end and competence. But before we go there, the other aspect of clinical application obviously relates to examinations, monitoring, and diagnosis. Can we talk a little bit about the diagnostic accuracy first in terms of comparing bedside ultrasonography or POCUS ultrasonography to other modalities for common medical conditions that we might encounter in the ICU?
Thank you, Sergio. Definitely, this was my personal experience. When I started doing ultrasonography out of my fellowship, I have huge roadblocks. And that actually, I'm not going to deny that actually made me an excellent critical care ultrasonography user, because it was a high stakes situation, probably one of the most prestigious group of cardiology in the country and in the world. And anytime I was having the pro in my hands, like, what are we going to say? And people will be, how are we going to document this in the chart? So I needed to find a way that I actually can justify the application. And I still believe it's a good way to start. Jose, what do you mean? Well, I was just not with the probe, putting the probe on people looking for incidental findings. I put the probe on patients that were having a clinical problem. So from the very early stages in my career on ultrasonography, I recognized that acute respiratory failure and undifferentiated arterial hypotension were two common clinical presentations where the tool and the ultrasonography itself, that evaluation, will allow me to take better care of my patients. And I want to make sure everybody understands that it's just not the image. I consider myself, at the moment I started practicing critical care ultrasonography, a good clinician. The secret here is how to actually build that hybrid between clinical excellence and excellence in point of care ultrasonography. If you are able to demonstrate that to me, you will most likely never will have a major issue. The problem is when you disconnect both. So going back to the question, I believe in acute respiratory failure, when I started reading about it and see how, I have a case I will share with you very briefly. 3 a.m. in the morning, patient goes from a MICU to a cardiothoracic ICU for ECMO commencement. I put the probe, I'm seeing large pleural effusion. I put 2 chest tubes, of course, with a good amount of time to not create more pulmonary edema. And I was able to drain 4 liters between the 2 hemithoraces. 6 hours later, that patient was back in the MICU. She didn't need an ECMO. I have that case. I have the pictures. I will never forget that case. How I started? With acute respiratory failure. What happened? Your chest X-ray does not perform at the level of lung ultrasonography for characterization of pleural effusion. So I started looking more and more in detail. So I would say that the diagnostic accuracy as it is right now, first of all, is probably the most cost-effective and with less side effects in terms of health problems than any other ones for acute respiratory failure and for shock.
So obviously are very common conditions in our practice, and I think hence the real interest in adoption or rapidly evolving adoption in the critical care world. Jose, you talked about obviously cardiac arrest. You talked about shock and respiratory failure, but cardiac arrest is often part of those diseases, unfortunately. Could you give us a little bit more of your thoughts of how to apply and the utility from basic to more advanced of utilizing point of care ultrasound during a cardiac arrest?
So you always finding the way to really go to significant problems, and that's a problem. You just mentioned in the last statement, you need to really achieve an advanced training to make a call in a cardiac arrest. So why critical care ultrasonography is not actually incorporated around the planet in every single cold blue? It is not. It probably will be one statement there, but it's not. There is no recommendation about that. Why? Well, number one, when you go to these international recommendations, they go by the evidence. So what is the evidence on that? Well, the evidence that we have at the beginning came out from Europe, and they were in pre-hospital cardiac arrest. And then in the last decade, we have actually many more studies. And those studies actually have been showing us that might be some value making prognostication. Do I use it for prognostication sometimes? Yes, I'm not going to deny that. But to make it standard of care for the care of caring for patients victims from cardiac arrest, I do believe you need to have advanced critical care echocardiography competence. I will tell you why. The reason why is because you will be under pressure. You will have limitations to make a call. And I want to make clarity to the membership of the podcast about, I'm talking about transthoracic echocardiography. So what has happened in the last 5 years is that several groups, and more specifically, most of those colleagues have been more from the emergency department. They actually have been smart, utilizing now transesophageal echocardiography for cardiac arrest because you decrease the variability on the assessment. And to be sincere with you, TE is easier than TTE. You have transesophageal echoes, clear pictures. You are not on the way of anybody. Once the patient intubated, you put the echo probe there. So during the last 7 years, there is mounting evidence, but the evidence, once again, is not at the level to incorporate in guidelines for management of cardiac arrest. So the way I look at it, this actually is one of my, has been, I'm a cardiac anesthesiologist as well. I have advanced certification in transesophageal echo. But the reason I'm mentioning this is because people like me need to empower an average intensivist. If for some reason there is a TE probe in that institution, he shouldn't be afraid to use it. And that actually is our next step. I'm predicting that in the management of cardiac arrest, there is a good likelihood that TE might be preferable over TTE. There is not that evidence there yet, but the way actually emergency medicine is doing what they are doing is becoming more and more resonating, and I think there is a good chance here that TE will perform. So I just want to leave it up there. I think that's a very promising aspect of point of care ultrasonography, but there are many political issues. There are potential danger because the patient might have esophageal rupture. That will be very hard for the American Heart Associations to say, yes, every single cold blue will have a TE or you have a TTE. How you can ensure that that person is competent to make a call that the patient will go to the OR or the patient needs TPA, whatever measure you are saying. So the bottom line is this is a promising area for point of care ultrasonography. It's very exciting, and at least you can start applying it. If you feel that your competency level is in the high end, and be open to actually have that quality assurance with the cardiologist. you believe that you make a good diagnosis, show those clips to the cardiologist. This is what I think it's. You have to have that kind of level, and you're able to do it, sure. And I will tell you, in publications I have made, or my respect that I gained in that first institution after I got trained, was based on saving people in cardiac arrest. But those anecdotes cannot actually lead to didn't allow me to lead that discussion of, oh yeah, now it's a standard, because that's not the way it's going to happen. We need more data.
Yeah, absolutely. And Jose, any comments on the COVID-19? Obviously, my experience has been that historically, if people are old enough as us, they might remember that the argument was that ultrasound is not good for the lung because of air back in the day. And now, obviously, more and more people are putting probes on the chest, looking at the lungs, and more than just fluid. So any comments on how it's been integrated or studied in COVID-19?
Absolutely. I think the WIN POCUS organization did a very good job with those, international guidelines. I like the fact that actually they organized that really well, because they identify those 9 clinical domains for diagnosis, of severe acute respiratory syndrome in COVID-19. So you triage, you were actually doing that assessment, following the patient closely. And actually, there were some investigations even correlating that with oxygenation, et cetera. So the initial triage and research stratification, that was huge. And then there were findings for the diagnosis of the pneumonia, not only that, cardiovascular disease as well associated with it. And then a screening for venous thromboembolic disease. And not only that, we were able to see what happens when we're proning the patients and whether or not there was a response to proning position and our fluid management. And then we are actually were able even to reduce the potential spread of infection due to that infection control that we might have with these devices, instead of having like the formal echocardiography from room to room. So I think has been very favorable and the personal standpoint. For instance, I remember, I think we included that in my publication last year. I did with one of my cardiology fellows, and this is the beauty of critical care ultrasonography. It takes you to the next level of see what you can do better as a clinician. That day, I prone a patient, and actually the patient was in a rotoprone, bed, and I was trying to see the heart in prone position, and I needed to kind of see how that contrast obtaining the apical view versus when the patient was in the clinical supine. I was able to obtain the view. I was able to actually distinguish the diastology function in both positions, etc. Try to see how the right ventricular function was different as well. And I learned on the fly. I never have done that in a patient that was with that disease in prone position. And it helped me out. And I think we put that, for one of our publications last year. So definitely that. The other one was, oh my God, I've been rescuing patients that have refractory hypoxemia receiving ECMO. Some of those patients have, single lumen catheter. The catheter was in malposition, displaced, and once again, we were able to publish that as well. And although I have patients like that before that had the malposition, etc., but in the case of COVID, what happened was that the ELSO was recommending a specific cannulation, and somehow some of the providers were not following the recommendations. So that was another way to engage cardiology colleagues and do what is right for the patient, know what they were wanting to do. So it once again, myriad of applications on COVID, Definitively, I think for any future pandemic, ultrasonography will be in the armamentarium, first line armamentarium for any clinician.
Perfect. I want to talk a little bit about challenges, and I know that we've offline have talked about challenges with POCUS, and really, from my understanding of how you view it, it goes beyond just diagnostic errors. So, if you could just give us some of your evident and hidden challenges with POCUS, I think that would be very valuable.
That's probably the first question that any person who wants to utilize the tool has to know. What are your limitations? Some of them are obvious, other ones are not so obvious. So if I share with you, the most common challenges, I will tell you the very number one, and please do not forget this from me, is time. Time. To do a good ultrasonography evaluation, you need time. I don't want to see you in a situation that you are not taking care of the patients. You have to round 15, 20 patients. I don't know what your practice is. It might be even only 8 patients, but 3 of them actually are sicker, or you need to discuss something with a patient about end of life, whatever. Ultrasound cannot deviate the attention of prioritization in your ICU. Ultrasound takes time to do it well. So time is number one. You need to become very organized. How are you going to do it? The ultrasound machine should be ready to go. You can have your wipes to get it ready, to get utilized. You can name a champion. Can be your fellow, your colleague, your nurse. If you're in a community hospital, the importance is that you have to be efficient. Okay? So the time is important. Number 2, the other limitation is to acknowledge that always will be people who would disagree with you utilizing the tool. And that what the impact that should have on you as a clinician will be only one: how I become competent. Once you are determined to become competent, the next step in that limitation is how I can relate to others, how I can start collaborating with others that are better than I on this. And that equals to radiologists and cardiologists. Right now, I can say here in this podcast, I'm very privileged because my cardiology leader in the institution I work in right now is the president of the American Society of Cardiography. Our discussions are very, very deep. I have instances where there was an AI company wanted to come to the institution. They approached me directly. And, just because he has access to all the resources and he has much more political leverage across the board, how can I put my ego first? Oh, yeah, they are coming to talk to Diaz-Gomez and probably want you to be the consultant for that company, etc. I don't care about that. What I care is I engage somebody who is a leader in a primary imaging specialty to be aware of that. I always tell him the problem that cardiologists have is they haven't been enough in the ICU to understand our reality. That's my primary interest. They come and they see what we face. So that's the third limitation I just mentioned, is the lack of collaboration. If you don't know how to collaborate with others, you will have issues with ultrasonography. People are going to block you. And the number 4 will be that ability, or the limitation itself will be not exposing you to feedback. You need to expose yourself to feedback. What I'm talking about is feedback from every standpoint. The nurses should tell you how I don't want to see patients with bruises, bleeding in the skin. I don't want to see gel on patients and not be cleaned up. I don't want, that's part of your professionalism. But at the same time, I don't want to see you believing that your views are the best and an expert or somebody who's more experienced tells you, hey, you know what? You should do better on this. I think you were describing a pleural effusion, but actually it was a pericardial effusion. Where's your quality assurance? Pretty much. Those are probably my top 4 limitations and a way you transition even before talking about that you make you have a mixed diagnosis, you have a diagnostic errors. So if you join me in that journey, I can predict that down the road, the possibility for you to end up on diagnostic errors is much less. That is, you from the beginning, you ignore these limitations, that you jump on this journey, but you become overconfident, you believe that you don't need anybody else, and you don't care about what other people say, and you just want to put this on the web. Look at my awesome diagnosis I made. And by the way, that diagnosis even might not change the outcome of the patient, to be honest. That diagnosis might not even change the mortality of our patients. So this point of care ultrasonography has made me more humble, and I still believe I need to learn more. For instance, believe it or not, I'm not that strong in 3D echocardiography because that's more utilized in the OR. And now I have spent the majority of my time in the ICU. I'm going back to the cardiac OR in March. And now I know I need to brush up my concepts on 3D. So see, everything becomes relative, and you really need to have that self-awareness, how you're going to utilize the tool. So please keep in mind these limitations, because what Sergio was mentioning is absolutely crucial in terms of preventing potential diagnostic errors down the road.
So before we go, I guess, to the next phase, which I think is a perfect segue, what I wanted to kind of encapsulate what you were saying is something that I've seen a lot over the last 2 years with the pandemic, which is obviously very well described in as a cognitive bias, which is the Dunning-Kruger effect, right? Which is the bias that people starting with a low ability, as they become more proficient slowly, will tend to overestimate their knowledge. And I think that's very easy in the world of point of care ultrasonography, because from maybe not getting any images of the heart, you now start seeing the heart, right? And that humbleness that you mentioned, Jose, I think is very important for that journey, no matter what level of expertise you have, but to always seek for coaching, to seek for other people's opinion, and to be open to feedback, because ultimately the goal is really to improve.
Thank you.
Go ahead.
No, please.
And we're gonna say this might be a perfect leadway to talk about competence and training and certification for intensivists. As we wrap up, if you maybe can just give us some thoughts. I know from your review article and from others that more and more medical schools are introducing basic ultrasonography into their curriculum, but still only 30% maybe have something, and there's tremendous variation there. More and more residency programs, more and more fellowships, but there seems to be still a lot of variation. And also, as more and more trainees get trained in ultrasonography, there's still a large number of practicing intensivists who may have varying degrees of exposure to ultrasonography. So how do we advance the needle for everybody, and what are the thoughts on competence and certification would be very helpful.
Thank you, Sergio. No better way to kind of start wrapping up. This goes to the core of my existence. This goes to the core to have my own identity. If you think about it, that 3 layers, you start with the inner component of identity, is who you are. And then the next one is process. And the last one will be basically the outcomes. So the problem people have is when they think about it, they just, I'm gonna use this, because they jump to the outcomes right away. I would claim to just go to the basics, who you are, okay, and an intensivist. Okay, are you an intensivist and POCUS practitioner? Okay, are you an intensive POCUS practitioner and competent, or even better, proficient in point of care ultrasonography? Once you answer that question, you can really, really go to that pathway or creating a community that have a unified identity. We don't have that yet. Why? Well, some people believe that you get a 2-hour training course, you're done. Some people believe half a day. Oh, some people believe you have to pay X thousands of dollars to have a certificate of completion. Well, some people believe that you can do this online and come and have the tool for several hours. So to answer your question, we actually advised the New England Journal of Medicine readership. What are the two questions remains to be answered, and one of them is that we don't have any uniformity on the way to obtain competence, unfortunately. Because of that, anybody who wants to do a trial on that might be welcome. What I can tell you is that what we have is, number one, medical schools. Okay, we have our medical education, big time. I will tell you why. When we wrote the manuscript, that was right. It was like one third of the medical school have curricula. This past month, 57% in a new publication. It's growing. And I can envision that in the next 2 years, it might be over 75%. That's a fact. So I think we need to go back to those bases. I think the medical schools will have it. So, Jose, but you're discriminating me. I'm not going to be in the medical school again. That was 30 years ago. What do you have for me? Well, I do believe that we need to have an entry point. I think that entry point has been discussed. I think the next way to do this in a good way, for you that you are a tremendous leader in this country for community hospitals, and I still respect you even more than many other academicians, you have the ability to start creating some strong focus committees on those community hospitals. Just bring people together. You guys create a committee. Do your own course. Know your own equipment. Name your champion. Start actually collecting data. There are people who are doing it. I will not endorse ever one organization versus another organization course, even though everybody probably has seen all what I have done for SCCM, and I owe the SCCM probably the majority of my experience regarding education in critical care ultrasonography. But I want to be fair. Everybody should be able. If you have the resources, if you can arrange that, if you can put your hospital to go to that course, go for it. Whichever is the organization. But I think from the practical perspective, somehow probably the organization has to think as well to offer those courses in the hospital. And for instance, I know that the SCCM is doing it. So we need to do that at that level. And once you do that, in terms of competence, okay. If you ask me, Jose, everybody has to become board certified in critical care echocardiography? The straightforward answer is no way. You don't need that. We did a publication a couple of years back with a travel Baron and others from Europe and Asia. And we put there that probably it's reasonable to have at least one person that is advanced. The other ones have basic competence in the ICU. And I think that's reasonable. And that's what would you do. There will be people actually who would like to have that critical care echo certification. Go for it. But I will tell you, for the most part, when we are utilizing this in the ICU, it's unreasonable to expect that's the way to do it. And the certification, I'm part of that committee on the exam, and the certification is another committee. And so far things are going well, I think. However, I'm there is a huge opportunity here for, as I said before, if we collaborate much more meaningfully with the cardiologists, we can actually ensure that our clinicians can have the number of examinations to prove the competency. And that's right now a roadblock there. And I want to be transparent. I receive calls, emails, Jose, we need to have that 150 study, how to do it. It's not easy. Now, I have done tremendous effort in my institution. My 2 anesthesia critical care fellows are expected to get out of the fellowship, which is only 1 year, with that certification. They work really hard, and that requires a lot of effort from me. By just me, as I said, my identity, how I will be in this podcast if I'm not ensuring that the next generation of leaders in anesthesia critical care do not have the certification to continue utilizing the tool and educate the following generation. I can't. So for that reason, it requires a multiple levels. The competence aspect requires is a multi-layer intervention. It's not only one piece to go into one course of spending $10,000. I have enormous sensitivity for our international and overseas clinical practices that actually don't have the luxury to spend even $500. I have been educating in countries that even $200 has been very hard for them, and I need to teach in a ratio of 20 students and 1 faculty versus what we do in the US, that most of the time is between 4 and 5. A good echo training, it takes you to that ratio. So I want to say in the end that, regardless which pathway you are taking, remember my own pathway. My own pathway was putting things together myself. And did I pay for one course? Probably yes. If I recall well, yes. But actually, it was a course where actually there were retirees that they have some valve pathologists and stuff, because I wanted real. I didn't want just the healthy volunteer. And I paid for that, and after that I said, well, now I can see the real pathology. Now I can contrast. So, and most of the people do that. They just go to the one that are the beautiful pictures with the normal healthy volunteers. So anyhow, remember the multi-layer intervention to tackle the issue of competence in POCUS is real. It's multi-layer. It's not going to be that simple, and requires everybody's commitment to take our practice to the next level.
Excellent. And part of the intent, obviously, of having this conversation was to get everybody to maybe make a commitment as the new year comes to wherever they are in their journey of POCUS in the ICU, to either move forward and learn something new and get better or more competent in answering specific questions or specific uses, or if they already feel that they've achieved the certification and consider themselves a masters, to then help others move forward in that journey. But I think your points are well taken, Jose, that it requires really a lot of effort from the individual. It's much more than just going to a course, and that ultimately there are different levels that would be perfectly suitable for different practitioners, right? But no matter who you are, you probably can improve your competency in utilizing POCUS to answer specific questions at the bedside and help your care of your patient. And I think that should be the goal for everybody moving forward. I would like to wrap up, Jose, with a couple of questions that are not related to the world of ultrasonography, if that's okay.
Absolutely, Sergio. Anything from you.
So the first question is about books that have influenced you the most, or books that you have gifted often to others.
All right. Yes. I think perhaps the book that has influenced me the most has been Essentialism. It's about the disciplined pursuit of less. It's written by Greg McKeown. And in that book, I was able actually to understand that whenever in my life, or even very often in critical care echocardiography, if it's not a clear yes, then it's a clear no. Like black and white, as simple as it is. If it's not a clear yes, then it's a clear no. Because we are all busy. They're gonna come to you with offers with this and that. And if people really now wants to have that prominence, social media, everything. And all of a sudden, you end up involved in many things, but you end up not doing even one meaningful thing for yourself, your family, and your patients. So that's one. The other thought I have in that book is that it really exemplifies really well about your highest priority is to project your ability to prioritize. If you don't prioritize for yourself, somebody else will do it for you, and you will lose control, and pretty much you you're not gonna do what you enjoy the most. So I always prioritize in my life based on that book.
Yeah.
The other,
Excellent book.
yeah,
I was going to say that when you mentioned the book, the first thing that came to mind is if you don't set your priorities, somebody will set them for you, right? And that was one of
yeah.
like the lessons I took, and I would definitely link this into the show notes. And sorry I interrupted you. You were going to say something else.
No, the other, basically, of course, I mean, not everyone who's coming to your podcast is a leader, but something that ultrasonography might allow you to do is to lead, and eventually, I think that was my case. I ended up leading ultrasound courses and projects, academic projects, and all those kind of things. So that's an interesting aspect of point of care ultrasonography. So the other book that I like is actually the book on leadership and self-deception. In that one, in that book for sure, that basically the author is the Arbinger Institute, but the the way I look at things is as a leader, you really need to go to the bottom of the problems. You cannot ignore things. And it's just to pretend that you are making out things and make them look beautiful once again, instead of actually going to the core and have that identity that you might have with others and really engage others with meaningful relationships is absolutely critical for your success as a leader.
Absolutely. And I would like to end with just asking you, what would you want every intensivist that's listening today, every clinician, whether a physician or APP, to know? It could be a quote, a fact, or just a thought.
Thank you for asking that. I would say the following. In order for us to have better leaders in the future, if you are in a leadership position, you don't need to spread the leadership everywhere. You should facilitate others to become leaders. And if you cannot be a mentor, you still can be a supporter. You probably wouldn't have seen me over the last decade in more than 2 societies. And that's the reason why. It is not my intention to be in 10 societies and every single ultrasound meeting the San Jose. No, no, no. I will be more interested in the people who wants to actually have the proper professional development to flourish. We need to give opportunity to others. We need to spread, we need to share that, um, whatever wellness you have right now, and I feel very strong about it. So that's the reason, pretty much, most of my investment with my time goes to the SCCM, or the American Society of Echocardiography, and I think I would like to support others in the other societies, because once again, it's not about you; it's about everybody. And we really need to be more sensitive with this participation. And I will tap the talent from the very early stages in their careers. If somebody has the drive, if somebody really wants to go to the next level, support that person. So that's a very personal belief. I'm not criticizing others that probably has much more talent than myself and probably have better abilities to be everywhere. But in principle, I think we need to share more what we have with our colleagues. That's my thought.
And I think that's a perfect place to stop, Jose. I really want to thank you for taking the time to talk with us, sharing your expertise on this fascinating area of critical care, but also sharing your wisdom outside of ultrasonography in terms of being very regimented and picking up what's important for ourselves and making sure that we can help others move forward as well. So I hope to have you back soon to talk about other topics. And once again, thank you for your time.
Thanks so much, Sergio. I look forward to see you in person soon in beautiful Houston. Thank you.
Absolutely.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.